Now we will continue our lecture on the levodopa, and right now we start summing up all the side effects. Rather, you must tell, because many side effects have already mentioned, right? Side effects of levodopa, right? Of course, we can divide it into peripheral side effects and central side effects. And peripheral side effects, right? Okay, let's start it in simple way, that when the drug is absorbed from the GIT on the way, right, some of it is converted by dopa decarboxylase enzyme into dopamine, and that dopamine can produce cardiovascular side effect, cardiovascular system side effects, and those were related with the heart and with the circulatory system. In the heart it was producing, yes please, now you have to tell me, tachyarrhythmias, is that right? And in circulatory system it can produce postural hypotension, right? Second group of side effect, another important was GIT related side effects, which was like anorexia, nausea and vomiting, especially when levodopa converted into dopamine can stimulate the chemotrigger zone, can produce nausea and vomiting. Another important thing that levodopa, when it is converted into dopamine, dopamine can stimulate the parietal cells and produce more HCl and activate the peptic ulcer. So this drug is contraindicated in patients with peptic ulcer. Is that right? About the GIT, then we can come to the side effects in the central nervous system due to excessive dopamine activity, right? If there is excessive dopamine activity in the striatum, the side effects of the group are called dyskinesias. We have already discussed about the dyskinesias. What are the different types of dyskinesias? There may be tremors, there can be chorea, there can be acetosis, right? And there can be, yes, akathisia, right? So there can be many different tics, there can be motor tics, there can be many types of abnormal excessive movements. Is that right? These are due to excessive dopaminergic activity in the basal ganglia or striatum. Then there is excessive dopaminergic activity, unwanted excessive dopaminergic activity in limbic system, especially mesolimbic system, and dopaminergic activity is excessive there. That may produce psychiatric complications, and these complications may be anxiety or agitation, insomnia, right? Because levodopa may be taken up by nerve endings which make epinephrine and norepinephrine. They convert the levodopa into dopamine, and then some nerve endings can convert dopamine into epinephrine, norepinephrine and epinephrine, right? So that may stimulate the central nervous system and even may produce insomnia and agitation, right? Confusion, and especially when there is excessive activity of dopaminergic system in mesolimbic system, that may produce delusions, hallucinations, nightmares, right? And euphoria. And there you have to remember that if someone develops, you can say, psychotic symptoms while he is on the levodopa, you should not treat that patient with, you should not treat those patients with typical antipsychotics, because in previous lectures we discussed that typical antipsychotics block the D2 receptors, right? Those patients should be treated by atypical antipsychotic drugs. Who remembers atypical antipsychotic drugs? That may be clozapine. Of course, whenever you remember clozapine, remember that destroys bone marrow, especially granulopoiesis. Clozapine is very dangerous. It can produce agranulocytosis. Anyway, clozapine, olanzapine, risperidone, quetiapine, right? All these drugs we have discussed in antipsychotic drugs. Right, so atypical antipsychotics should be used, right, if patient develops some features of psychosis while patient is on the dopaminergic therapy, right? Parkinson's patient on dopaminergic therapy. Then there is another very, very special group of side effects, right? These are called response fluctuations. Response fluctuations. Right, these are very important unwanted actions which develop when there is long-term use of levodopa, and we have to understand it very clearly why there are response fluctuations. First, I will give you the example what happens with the patient, and then later on I will explain what is the basis of those problems. As I told you in the beginning, in last video, that when you start the levodopa, in 1/3 of the patient they have very good response because they have enough number of nerve endings to take up the levodopa, make the dopamine, store the dopamine, and keep the striatum normally functioning. Is that right? Then I told you that in 1/3 more patients, response may be mild or moderate benefit. Why? Because maybe there is excessive degeneration of dopaminergic pathway, and if there is excessive degeneration of dopaminergic pathway, there are less nerve endings available here to handle the levodopa, convert into dopamine and store the dopamine, right? Due to that reason, there is less response. Then I also told you that there is some patient, unfortunately, when you give the levodopa, there is no benefit, no significant benefit. Probably there is advanced loss of the nigrostriatal pathway. There are very few nerve terminals there, so there is no significant advantage that these few terminals cannot convert enough levodopa into enough dopamine, and so that striatal dopaminergic transmission is not corrected. Is that right? Now let's talk about one more concept, that those 1/3 of the patient which have very good response to levodopa, as years pass by, response become less. Again, we have discussed the cause. Cause was, what was the cause? That over the years the progressive loss of neurons, and over the years there is also you can say changes in dopamine receptors as well as receptor signaling mechanisms. All those things reduce the response. But over the years, a very unusual type of group of side effects develop. One is all that group of side effect is called fluctuating response. One thing is that in some patients who are responding previously, very well to the drug, they develop end of dose achinesias. They develop a very special type of side effect which is called end of dose achinesias, right? And some patients develop another type of complication which is called on-off phenomenon. Now I will explain them. What are these phenomenon? First of all, end of dose akinesia. Actually, what really happens that, let's suppose you are taking your dosing every 6 hours, right? If you are taking your dosing every 6 hours, if there is some loss of the neurons, maybe in the beginning when you take the dose, within 30 minutes to 1 hour, drug reach to central nervous system. Is that right? But if neuron terminal number become less, then neurons terminals cannot store enough dopamine to keep on working for a long time. So before the next dose, before you take the next dose, due to reduced number of neuronal terminals and due to reduced capacity of neuronal terminal to store the dopamine, there is sudden deprivation of dopaminergic activity in the striatum. Is that right? Again, listen. Let's suppose this is the action of the first dose. I will make a diagram here to explain it. Let's suppose this is you are taking the dosing. This first dose, this is second dose, and this is, let's suppose, third dose. Now, let's suppose these are the serum levels of the drug. Now what really happens, let's suppose at this level, at this serum level, you get the therapeutic action, therapeutic benefits of the drug. When drug level in the plasma is more than green line, when drug level in the plasma is above the green line, you are getting the therapeutic action. Patient is feeling good and can make the proper movements. And if patient therapeutic level of the, I'll make it blue. If drug level in the plasma goes up to above this level, patient will develop toxicity, right? So it means initially this is therapeutic window. The drug should be within this window. If plasma level is less than this, patient will have no benefit. And if plasma level is between green line and blue line, patient will have the good benefit. And if plasma level of the drug goes above that, that will produce toxicity. Am I clear? Now what really happens? Actually, as time years passes by, nerve terminals become less. When nerve terminals will become less, then capability of nerve terminal to make the dopamine and store the dopamine is reduced, right? And then in the end of the dose, neurons cannot, what they cannot do? They cannot release enough dopamine and its action is lost, right? Let's suppose that in this patient, action of first dose is going from, look, this is first dose action from here up to here. So we can say this is the duration of first dose action. Then second dose action is added to that and that continues up to this level, is second dose action. And third dose action is from here up to, let's suppose here. It means in this patient in the beginning, right, there's a very good response going on. He's having therapeutic action throughout. Now, when neurons number is reduced, this bar from the end start shrinking, right? Let me explain first with single dose action. Let's suppose this is single dose and you see how the action goes. Is that right? This is therapeutic level and this is the, let's suppose, toxic level. Now in the use of single dose, from this point up to this point, you are having the benefit of the drug. Is that right? When plasma level is in between. But when neuron terminals become very less, even if plasma level is here, they cannot store enough and release. So in the beginning of the disease, action of the drug was in this bar. As disease advances, action of the drug become less. As disease further advances, terminals become less, right? So action is also reduced. Are you understanding what's happening? As nerve terminals becoming less, the duration of action of the drug is becoming less. Is that right? Because initially when nerve terminals were in good number, even low level of the drug was enough drug to be converted into enough dopamine. But when neuron number become very less, then drug level has to be very high, so that very high level of drug enters into neurons and neurons are pushed to work enough. And as soon as high level little bit drop, action terminates. So it means with the time, the duration of action will increase or decrease. It will decrease. And then another trouble will start. Here, in this situation, patient is having first action of the therapeutic action of first dose. Before it finishes, he has the advantage of second dose. Before that finishes, he has the advantage of third dose. Do you think there's on and off phenomenon here? No, there's a continuous therapeutic advantage. Now, as neurons are more and more lost, then we can say this bar, green bar is pushed upward. When green bar will be pushed, let's suppose here. Now what happened? Patient will find that action of the drug start at this point suddenly and terminate here. Then action of the drug, so it means this is on point and this is off of the drug. And patient become really on here. On mean he's able to move around. Is that right? And by the time drug level just drop from here to here, he become frozen, akinetic, hypokinetic. So patient now undergoes which phenomenon? On and off phenomenon. Previously, it was from here up to here throughout action. Is that right? But as disease advantage, number of neurons become less, right? Then only neurons produce satisfactory mobility of the patient only at higher concentration. Is that right? And as soon as concentration goes down, action of the drug is lost, right? So patient develop a problem which is called on and off problem. On and off problem has multiple reasons. One reason is this, that number of neurons has become less. Number of neurons also affect in another way. Let's suppose someone has more neuron in the beginning of nerve terminals in the beginning of the disease. If you have more terminals, even if drug level goes really very down, terminals keep on working in a natural fashion and to keep some mobility. So patient will not be off suddenly. But when terminals become very less, as soon as drug is down, terminals are so less in number that themselves, by their own action, they cannot keep any significant mobility. Patient become really frozen. Am I clear? This problem has these fluctuating responses are two examples. First, patient develop end of dose. What is this? Achinesias. There, for example, patient who is maintained well on the previous dose, right? Initially, patient complained, I was taking only 3 or 4 doses in a day, and I was happy. Then after 1 year, he may complain that I'm keeping the same doses with the same duration, but before taking, at the end of the first dose and before the beginning of the next dose, he says I develop severe immobilities, hypokinesias. That is called end of dose achinesias. Some people develop in a way end of dose achinesias only early off phenomenon. At more advanced stage, they start undergoing severe on and off phenomenon. Now, am I clear to you why on and off phenomenon occur? Because in between the doses, there is extremely reduced dopaminergic activity. Due to that reason, patient become totally off. And when you give the drug, when drug goes really at a higher level, suddenly patient become active. Now, how do you manage on and off phenomenon? Of course, the ideal should be you give some neuroprotective drug so that there should not be further loss. Right? We'll talk about that later. One way to manage the on and off phenomenon is that increase the total dose of the drug and make it smaller frequent administrations. Because, look, in this patient, let's suppose bar is going up, right? Then bar may go up really so high. Do you think previous doses will have any action? No. Now what you do? You give very heavy dose to keep the action. Now actually for a short time, patient is normally mobile and then he becomes developing pathological dyskinesias. So with on and off phenomenon, there's another entity come when you increase their dosing that patients start developing dyskinesias. That as soon as patient become on, he becomes super on after some time and then he become off. For example, now every day, for example with previous dosing, every day, let's suppose 4-hour interval he is on, then off for 3 hours, then 4 hours or 2 hours on, then off. And when he is on, even that time does not give the pleasure to the patient because very soon on becomes super on. Super on means there is overstimulation of the striatal system and patient develops tremors and patient develop choreoathetosis and patient may develop other extra tics and other extra movements. So what are the problems in a patient who is taking levodopa over the years? That before the response to treatment totally finished, person initially develop end of dose achinesias and eventually develops severe on and off phenomenon, right? All these problems are occurring due to changes in the number of nerve terminals in the striatum due to progressive degeneration plus due to adaptive changes in dopaminergic receptor and their signaling mechanism. How do you fight with that? One way was that we give doses more frequently. Rather than giving every 6 hours, we make it every 4 hours, then we make it every 2 hours. The advantage of frequent dosing is that, let me make a diagram here so that I explain how the frequent dosing can solve problem at least for a while. Let's suppose these were the 3 doses. Okay, these were equal 3 doses. Now in these doses, these were your therapeutic and this was your toxic line. Is that right? Now, when therapeutic window goes up, it comes to this level. Now patient is developing on and off. Here it become on, here it become off. Here it become on, then off, on and then off. Do you think now patient will be happy? Not happy. If you treat it by simply increasing the dose, let's suppose therapeutically we really increase the dose too much, rather we increase it further. Now on-off phenomenon may be solved, but there will be severe dyskinesias during this time. So is it a right approach? Another approach is you just make frequent dosing. You are getting it? So that trying to maintain the level in therapeutic window. Is that right? This is one way how we deal with the on and off phenomenon. Another way to deal with the on and off phenomenon is, why don't you give some directly acting dopaminergic receptor stimulator? Because if you give the patient now you start other strategies. One strategy was that you give the drug which can directly stimulate the dopaminergic receptors. Now, as these neurons are undergoing degeneration, right, what we do that we directly stimulate the dopaminergic receptors here. And these drugs have longer duration of action. So when this very less number of terminals, when it is showing on and off phenomenon, but direct dopaminergic receptors will be still working. Are you understanding? So when these nerve ending system become off, direct is still keeping it a little bit active. So do you think off problem will be solved or not? It will be solved. And to reduce the on problem, we reduce the levodopa dose. So these days what we do, when on and off phenomenon start, one of the way to manage is that we do some dopaminergic therapy different than levodopa. What are those therapies? We want, one way is give the direct dopamine receptor agonist, so that when levodopa is in off phase, some actions still keep on going on. Or we give selegiline, so that whatever you can say dopamine is recaptured is not destroyed rapidly. So system does not become off easily. Are you understanding? Or we give Comt inhibitor, so that dopamine does not destroy rapidly and still it remain in small amount and keep the system functioning. Is that right? Or we give Amantadine. So all these other strategies other than levodopa, they can help to manage the problem of on and off. What you do, either you try direct dopamine receptor agonist, or you give selegiline which inhibits monoamine oxidase B, or you give Comt inhibitors, is that right, which also help in less destruction of dopamine and maintaining some dopamine level there, right? So all these things are added to the levodopa therapy to reduce the off problem, and to reduce the on problem, we further reduce the dose of levodopa. Am I clear? No problem here. So these was the side effects which were response fluctuations. Then there is some miscellaneous side effects, like when you give levodopa, it may be taken up by the nerve endings in in the iris there are sympathetic nerve endings, and if in the iris sympathetic nerve endings take up the dopamine, they convert into norepinephrine and release norepinephrine, then what will happen to pupil? It will undergo pupillodilation, right? Because this is a pupil and these are your dilator pupillae muscle, and dilator pupillae muscle have alpha 1 adrenergic receptors, and there are sympathetic nerve endings there. So these giving levodopa may stimulate these nerve endings, and patient may release more norepinephrine. So sympathetic activity in the iris is increased. So pupillodilators work hard and dilate the pupil. Dilation of pupil is dangerous in patient with closed angle glaucoma or narrow angle glaucoma. You know what is narrow angle glaucoma? Anyone? Okay, let me explain. Because levodopa is contraindicated in narrow angle glaucoma. And why it is contraindicated? Let's discuss that. Let's suppose that here is your cornea, of course, right? You must be knowing that normally aqueous humor is produced by ciliary body. Aqueous humor moves from the posterior chamber of the eye through the pupil into anterior chamber, right? So after that, aqueous humor drains in this area. Here there is trabecular meshwork and here is canal of Schlemm. You have heard of these things? Canal of Schlemm. So what really happens, this is called the angle, right? Through this angle, aqueous humor drains into venous system. Am I clear? Now, what really happens, that this is your, let's suppose, what is this? Iris. This is root of iris. Now, if we do pupilloconstriction, it means this iris is lifted away from the root, an angle opens. If we do pupilloconstriction, then iris is pulled away from the root. If we produce pupillodilation, it is opening up. It means iris will accumulate at its root and that may clog the angle. Now some people have narrow angle. If someone has a narrow angle, this point is already narrow, so aqueous humor is being produced normally but it cannot drain well. So intraocular pressure will go up. That situation is called narrow angle glaucoma. Glaucoma means raised intraocular pressure. Narrow angle glaucoma means that glaucoma is due to narrow angle at the drainage. Now if a patient has narrow angle glaucoma, at the top you give any drug. It may be levodopa, it may be atropine, any drug which is pupillodilator. You know what will happen? As soon as it will dilate, because angle was already narrow, as pupil will dilate, iris will be collected at the root of angle, right, and block the angle. And whatever little drainage was there, that will be also blocked. And narrow angle glaucoma will undergo acute phase. And patient will develop severe pain in the eye and eye will become red, right, very red painful eye. And if you don't relieve it fast, intraocular pressure may be so high that it may lead to permanent damage to the optic nerve, right? So what I was telling, that any drug which is pupillodilator is contraindicated in patients with narrow angle glaucoma. Rather, it's worth mentioning that the treatment in the acute phase of narrow angle glaucoma, treatment is pupilloconstriction. We give pilocarpine. Patient who have narrow angle glaucoma, in acute phase, we give them drops of every 2 hours, we give the drops of pilocarpine, so keep it constricted. So keep the root of iris pulled away so that there should be better drainage of aqueous humor. Am I clear? So because this drug can produce mydriasis, it is contraindicated in patient with narrow angle glaucoma. Is that right? Another important thing, which is not a side effect but unusual situation associated with levodopa, that levodopa may appear into body secretions, including it may appear in saliva or in sweat, or it may appear in vaginal secretions or urine, and turn all those things brownish color, right? Then another situation which I should mention is that sometimes we give drug holidays to these patients. What are drug holidays? That we don't give drug to them for few days. Advantage of that is that whatever receptor disturbances or postsynaptic membrane has developed, dopamine receptor down regulation or maybe the signaling mechanisms, they may be corrected. But this is a risky business. And these days, in most of the situations, we should not give drug holidays, because previously it was very popular, but we found the problems with that. When you give the drug holiday to a patient with levodopa, you are giving drug holiday because you think in for few days when he is not taking the drug and you will start the drug again after a few days, then there will be good response. Maybe patient never comes back, he dies. The reason being that when you give the drug holiday to a patient, if patient is really having severe Parkinsonism, he develops severe hypokinesia. Even he cannot swallow his own saliva, and that may produce bronchopneumonia, because saliva with infected bacteria may go into respiratory channels. So many patients who are on drug holiday, now the research has told they die of maybe bronchopneumonia, or because they become so immobile that they develop a prolonged stasis in veins, and deep venous thrombosis may develop and pulmonary embolism may develop, they die of that. And if they really don't die, they may come back to you, but they're severely depressed with this experience that they're totally handicapped, they cannot move, right? And if you are very adamant to give drug holiday, then you have to take care that there should be someone around who can take care of the patient, especially those days when patient is on the drug holidays. Is that right? So many patients die of pneumonias, or they die of you can say pulmonary embolism, or they may develop severe depression during the drug holidays, right? Levodopa is contraindicated in some situations. Of course, any patient who has a history of psychosis, will you give levodopa? No, because psychosis in psychotic patients there is excessive dopaminergic activity. At the top, if you give them levodopa, you may precipitate another attack of psychosis. Is that right? Then it is also contraindicated in narrow angle glaucoma. You know it, why? This is contraindicated in severe cardiac diseases, especially when patient has, because this is elderly patient who develop Parkinson's disease, and if they have cardiac problems, especially tendency for tachyarrhythmia, do you think we should give levodopa? We should not. Then patient who are having active peptic ulcer, we should not give levodopa because active peptic ulcer may bleed. And then some rare situation, but levodopa should not be given in patient with melanoma. Of course, melanoma is a misnomer. It is not a benign tumor, it's a malignant tumor. That is why it is called malignant melanoma. Patient who have malignant melanoma, history of malignant melanoma, or patient who have some skin lesions which are yet to be diagnosed and you are not sure it is melanoma or not, should not be given levodopa. Why? Because levodopa can convert into it is a precursor molecule which can be converted into melanin. And if patient has malignant tumors, that will be very happy to find the levodopa around and take up the levodopa and become fully active and start making melanin, and during that process it may start multiplying, and cancer may spread again or it may be reactivated in the body. So for melanoma patients, levodopa is contraindicated. That's all about the levodopa. Let's have a small break and then we'll continue with the rest of the drugs. Now we will continue our discussion in the management of Parkinsonism. We have already discussed levodopa in detail, right? And we have already discussed that if this is a dopaminergic neuron, this is GABAergic neuron, and this is basically, it is coming from the substantia nigra, and this synapse is present in corpus striatum, right? We have already discussed that basically this is a point where levodopa comes, strategy number 1. Now we will go and move forward. What are the other options available, right? The other very important option available is the drugs which can directly stimulate the dopamine receptor. Let's suppose this is dopamine receptor, and drugs which can directly stimulate the dopamine receptors. These drugs are called dopamine agonist, dopamine receptor agonist. Right? Dopamine receptor agonists are primarily have some advantages over levodopa. One advantage is dopamine agonists directly work on the receptor, so they don't need metabolic conversion from precursor into dopamine. Levodopa need to be converted into dopamine by the action of which enzyme here? Dopa decarboxylase. Is that right? But the drugs which are directly receptor stimulant, they don't lead enzymatic conversion. This is one advantage. Secondly, these drugs do not require any number of functional terminals. Action of the levodopa depends on the presence of the functional dopaminergic terminals. Is that right? Because levodopa need to be converted into dopamine, then stored and then released. But these drugs which are dopamine receptor agonists, they can directly act on the postsynaptic membranes to stimulate the dopaminergic activity. Is that right? In these ways, these drugs are superior to levodopa. Now, these drugs are primarily of two types. Number one group of drug is from ergot alkaloid, ergot derivative. And others, the new drugs are non-ergot derivatives. These are the new drugs, non-ergot derivatives or the ergot derivatives. The drugs which are in ergot derivatives, these are, yes please, you must be knowing by now, these are pergolide and yes, bromocriptine, right? And non-ergot derivatives which are now considered superior because they don't have as many side effects as are the ergot derivatives. Let me write here, ergot derivatives have more side effects. Now, non-ergot derivative drugs are, yes please, pramipexole, and other is ropinirole. Now, especially pergolide, they stimulate D1 receptor as well as D2 receptor. Bromocriptine especially stimulate D2 receptor, right? And pramipexole and ropinirole, they stimulate D3 receptor more than D2 receptors. But anyway, all of them are stimulating the dopaminergic receptors, right? Now, these dopaminergic receptor drugs, they have certain advantages. They can be given to the patients who have end of dose achinesias. These drugs can also be given successfully in a patient who are having on and off phenomenon with levodopa. And these drugs can also be used in the patient who are resistant to levodopa. So these drugs are really great drugs, right? These drugs are really great drugs, right? They are having three wonderful magic things. What are those three wonderful magic things? Yes, number one, end of dose akinesia patients will be responding well to these drugs. Patients with on and off phenomenon on the levodopa will be responding well, and even some patients who are resistant to levodopa may also respond to these drugs. Is that right? And you can also give these drugs in combination with levodopa, that when patient on levodopa start developing the on and off phenomenon or other response fluctuation, you can introduce these drugs and they will smooth out the response. Why? You remember on phenomenon was due to sudden dopaminergic activity enhancement, and off phenomenon was due to sudden deprivation of dopaminergic activity, and really this phenomenon was because neuronal terminal were very less to handle properly the levodopa. But when you are giving these drugs along with the levodopa, then naturally these drugs directly keep on stimulating to some extent the dopaminergic neurons. So even when before the on phenomenon, these drugs are still working, so there is no true on. And even when off phenomenon come, when activity of the levodopa really drops, these drugs keep on working, they have longer half-life, and due to that reason, on and off abrupt fluctuations in the response are ironed out. Am I clear? No problem. Right, then and now there's a trend that these drugs are being used as first-line drug as well, right? Either we give levodopa or these drugs, any one of these group as a first-line drug, or combination of these two groups, levodopa with carbidopa plus any one of these drugs. When you think of pramipexole, there is something good about it, something like pram. You would love to dance if you hear about that. You know what is very special thing about it? This drug is proven to be neuroprotective, right? This drug or its metabolites have some antioxidant activity, and they believe that when this drug is working on nigrostriatal pathway, due to its antioxidant activity, it reduces the further loss of neurons to some extent, right? Because it reduces the further loss of neurons in nigrostriatal pathway by working as an antioxidant, right? This is considered neuroprotective, right? Now we talk about the very important side effects of these group of drugs, right? Some side effects are common. Look, side effects can be really some side effects which are especially related with ergot, some side effects which are related with these drugs, but most important side effects are due to excessive dopaminergic activity, because all of them are directly stimulating dopamine receptors. Because all these drugs are directly stimulating dopamine receptors, so of course, if you give excessive dose, there will be unwanted excessive dopaminergic activity in central nervous system, and that may lead to all the side effects which are due to excessive dopaminergic activity. By now, you are very well knowing those side effects. For example, when dopaminergic activity is too much in the GI related with the GIT, that will produce anorexia, nausea and vomiting. When dopaminergic activity is too much on basal ganglia, striatum, what will happen? That will produce dyskinesias. And you know all type of dyskinesias which can be produced by the excessive levodopa, they can also be produced by the excessive activity of dopaminergic agonist drugs. Then excessive dopaminergic activity in the mesolimbic system, that will produce psychiatric side effects. So all these drugs can produce psychiatric side effects as like anxiety, or they can produce hallucinations, delusions, and right, even frank psychosis, right? So dyskinesias can be produced by acting on basal ganglia or striatum. They can produce psychiatric complications by acting on mesolimbic system. By acting on chemotrigger zone, they can produce nausea, vomiting. Is that right? And now we come to some special side effects. Special side effects which are related with, especially with ergot alkaloids. These are very important to remember. Number one, they can produce pulmonary infiltrate. Number two, they can produce, what is this? Digital vasospasticity and gangrene. You know, ergot alkaloids sometimes produce very strong vasospasticity in distal vessels. And if these vessels are strongly vasospastic, especially arteriolar vasospasm, may produce severe ischemia to the fingers and may precipitate gangrene of the finger. So that may lead to digital vasospasm, right? Then these drugs can also produce another side effect that is called erythromyalgia. Erythromyalgia. In erythromyalgia, what really happens that, especially in the feet turn red, they turn tender, painful and swollen, right? Patient feet may turn red, tender, swollen and painful, and this problem may occasionally occur in the hands also, and sometimes even involve arthralgia. The good news is that if you stop the drug, within few days, erythromyalgia complications disappear. Is that right? So these are some special side effects, and we are not very happy about these ergot alkaloids, that they can produce pulmonary infiltrate, they can produce severe vasospasticity in the digital vessels, they can produce erythromyalgia, red hot swollen feet, is the right, sometimes even hands, right? And of course, ergot alkaloid has all the side effects which are due to excessive dopaminergic activity, which may be anorexia, nausea, vomiting, which may be dyskinesias, which may be psychiatric complications, and of course, you must not forget that excessive dopaminergic activity can produce also cardiovascular problems, including cardiac tachyarrhythmias. These are drugs, pramipexole and ropinirole, they don't have ergot specific side effect. That is why now they are more used as compared to pergolide and bromocriptine, because they are not ergot derivative. So naturally they are not producing the pulmonary infiltrate, they are not producing strong digital vasospasticity, they are not producing erythromyalgia, and right. So you can forget about the ergot alkaloid side effects when you are using these two drugs, but they produce and of course they produce all the side effects which can be due to excessive dopaminergic activity. Again, you must be knowing excessive dopaminergic activity on limbic cortex will produce psychiatric complications. Excessive dopaminergic activity by these drugs on basal ganglia will produce dyskinesias. Excessive dopaminergic activity on chemotrigger zone will produce nausea, vomiting. Excessive dopaminergic activity on the peripheral part of the body may produce cardiovascular complications. But they have their one special side effect. Who will tell me what is that side effect? Sometimes they produce the attacks of full attack of irresistible sleep. Even patient driving on the highway may undergo sleep. Thank God these side effects are not common. So these are very unusual side effects of pramipexole and ropinirole, and you must mention it to your patient because some of these patients may undergo irresistible sleep attacks, and that may be hazardous for the patient or even to the other people. If patient is using some machinery, rapidly moving machinery. Is that clear? So sleep attacks is one unusual side effect. Now we come to the next group of drugs. We have discussed levodopa, we have discussed direct dopamine receptor stimulators. Now we go to the next group of drugs. Let's talk about monoamine oxidase B inhibitors. Yeah.
Can you use bromocriptine for hyperprolactinemia?
Okay, yeah, Asan remember something very special. The bromocriptine has one very special use, and what is that use? For hyperprolactinemia. Because bromocriptine can stimulate the dopamine receptors on the anterior pituitary cells. In the anterior pituitary there are lectrotrophs which produce prolactin. In the anterior pituitary there are prolactin producing cells, and these cells have dopamine receptors, and if bromocriptine work over there, then those cells will be inhibited and prolactin production will be less. This is used, bromocriptine is used to reduce prolactin level in females who want to stop the nursing to the baby. When females are producing milk, right, and when they want to stop the nursing, they use bromocriptine. And another use is when someone has a tumor of anterior pituitary in which he is producing heavy amount of prolactin producing tumors. Then also we use the bromocriptine so that the tumor or adenoma produces less bromocriptine and produces less prolactin, and excessive prolactin lead to amenorrhea. So hyperprolactinemia, amenorrhea syndrome can be managed by bromocriptine. Am I clear? No problem? Thank you. Now we start the next group of drug, that is the drugs which are inhibiting monoamine oxidase type B enzymes. Of course, the top of the drug in that group is selegiline, right? So the drug which is here, monoamine oxidase B inhibitor, monoamine oxidase B inhibitor, and the name of the drug is selegiline. Now selegiline is a drug which is bind with monoamine oxidase B, and monoamine oxidase B are the enzymes which break down the dopamine, but monoamine oxidase A are different enzymes which specially are interested in breaking down norepinephrine and serotonin. Epinephrine, norepinephrine and serotonin are broken by monoamine oxidase A, and monoamine oxidase B break down dopamine. Luckily we have this selective drug which will not work on monoamine oxidase A, but in therapeutic doses it will work only on monoamine oxidase B and inhibit them. In this way it will reduce the catabolism of dopamine. So naturally then dopamine which is recaptured, if it is not catabolized, it will be added to the store. It will be taken up by the vesicles. In this way stores of dopamine become more efficient. Is that right? This is one advantage, and naturally then dopamine supply to the striatum become better, and clinical features related with the Parkinsonism will be reduced. Is that right? Again. But it has one more advantage. Actually selegiline is also neuroprotective. One of the metabolites of selegiline is antioxidant, right? And they believe that it further reduces the loss of nigrostriatal neuronal disintegration or degeneration. Is that right? So now we know two neuroprotective drugs that we believe that there was pramipexole there, right? That was also neuroprotective, as well as selegiline is also neuroprotective, right? So selegiline, about the selegiline, you have to remember one thing, that in very high doses it loses its selectivity and start inhibiting monoamine oxidase A as well. Selegiline should not be used in the patient who are already on SSRIs. What are SSRIs? Selective serotonin reuptake inhibitors, right? Because when you are on SSRIs, right, your neurons are not recapturing serotonin, serotonergic levels are high, and if you give selegiline and at a little higher level of selegiline, if monoamine oxidase A is also slightly inhibited, serotonin crisis will come. Is that right? Then selegiline should not also be combined with other drug like non-selective monoamine oxidase inhibitors like phenelzine. Phenelzine is used where? Antidepressant, right? So there are non-selective monoamine oxidase inhibitors which inhibit A and B both, and if patient is depressed and he is on monoamine oxidase B inhibitor, monoamine oxidase inhibitors non-selective like phenelzine at the top, Parkinsonism, please don't give. Selegiline, is that right? Another related drug is rasagiline. Rasagiline, right? This is more potent than selegiline, right? Now we come to another, what will be the side effects of selegiline? Again, maybe due to the excessive activity of dopaminergic system in the brain, and I think no fun in explaining those side effects. Is that clear? Now we come to the another group of drugs which can inhibit COMT. Just you have a question.
For the drugs that do not have neuronal protective action, you said that you mentioned about antioxidant. If we give supplements of vitamin E, which is an antioxidant, can it help all the drugs?
Yes, there's a lot of research going on that I will discuss in the end of the lecture, that researchers are really working and looking for such antioxidant which can specially concentrate in substantia nigra and neutralize the offending agent, right? We'll talk about that later. Okay, now we come to the drugs which are catechol-O-methyl-transferase inhibitors. Is that right? And what were the name of these drugs? Okay, let's come to the drugs which inhibit catechol-O-methyl-transferase. Yes, what are the names of those drugs? COMT inhibitors. Yeah, alkapon group. What was that? Tolcapon and tolcapon. Thank God we have discussed a lot about it already. And entacapon. We discussed that these drugs will inhibit COMT. COMT is present in the peripheral part of the body as well as in central nervous system, right? When you give the drug to these patients, remember tolcapon can go to the central nervous system because it is lipid soluble, but entacapon work mostly in the peripheral part of the body because it cannot cross blood-brain barrier. But tolcapon has a very important side effect. I told you it has L, and it should remind you liver toxicity. Is that right? Tolcapon has liver toxicity. That is why, because it can be hepatotoxic, it is less commonly used, and if you really want to use it, you have to take a written consent from the patient. More commonly we use entacapon, right? Advantage of using this type of drug is that peripheral conversion of levodopa, right? Peripheral conversion of levodopa into what? 3-O-methylated dopa is reduced because the enzyme, this is COMT enzyme which convert levodopa into 3-O-methylated dopa, right? This enzyme is destroyed by or inhibited by tolcapon and entacapon peripherally. And once this enzyme is inhibited, then 3-O-methyl dopa is not formed, and most of the levodopa is available to go to the central nervous system. So number one, by blocking COMT, we increase the bioavailability of levodopa at the site where the real action is required, where levodopa can be converted into dopamine, that is striatum. Number two, as I mentioned in the previous videos, that 3-O-methyl dopa actually inhibits the entry of levodopa to the central nervous system. Why? Because at blood-brain barrier, the mechanism which transport levodopa from the blood to the central nervous system, the same mechanism is also used by 3-O-methyl-dopa to enter into central nervous system. Am I clear? So let's suppose if this is blood-brain barrier and this is a transporting mechanism which is taking levodopa up. Unfortunately, same mechanism is used by 3-O-methyl-dopa. And this metabolite, when it will engage this transport mechanism, then less levodopa will be transferred to the central nervous system. So by giving these drugs, we have two advantages. Number one, listen, when we give Comt inhibitors, number one, that they don't allow the levodopa to be in the peripheral part of the body to be converted into 3-OMD. So more levodopa is available to go to the central nervous system. Secondly, by reducing 3-O-methyl-dopa, right? These drugs reduce the level of competitors for entry of levodopa to central nervous system. And number three, if you are giving tolcapone, then in central nervous system also COMT is inhibited. So whatever dopamine is available, it will not be destroyed by COMT, and again it is available to be restored and re-released and reused. Am I clear? Right? And I told you, I mentioned previously that there is a combo, tri-combo, that in which you put levodopa plus you put carbidopa plus you give entacapone, and that combo is called Stalevo, right? This is now getting very popular these days. Then we talk about the side effects of these drugs. Too easy. What they can do? They can enhance dopaminergic activity in the brain. They can enhance all the side effects of levodopa to the central nervous system. That is why when you introduce these drugs, levodopa dose should be further reduced. Because levodopa is not being inactivated in the periphery, and it is also more efficiently transferred to the central nervous system in the presence of these drugs. So levodopa toxicity can occur. So these drugs can produce some side effects which are, they can enhance the side effects of levodopa, and they can produce some side effects like levodopa, right? Plus they have their personal side effect, in which I have mentioned already that tolcapone produces liver or hepatic toxicity. Now we come to the next group of drug, and before we go to the next group of drug, I would mention a very special drug. Sometimes patient at advanced stage of the Parkinsonism, I told you on and off phenomenon become very severe, and some patients become totally immobilized and they are really frozen in the off stage. And we have a wonder drug. We can inject a drug subcutaneously, and which will immediately start stimulating the dopamine receptors and person become mobilized. This wonderful mobilizer is apomorphine. What is the name of the drug? Apomorphine, sorry, corrected. The name of the drug is apomorphine. Apomorphine is a powerful stimulator of dopaminergic receptors. So this is specially used. It is injected subcutaneously, and it starts its action within 10 minutes, and its action usually lasts for about 2 hours. So if old man has some special occasions and he needs to be mobilized and he is really frozen, right, then what you will give him? Apomorphine injection, right? For at least for 1-2 hours he will be in action. Is that right? So why you are smiling in a very, very suspicious ways? Old men need to be mobilized as well. Even old women need to be mobilized as well, right? So whenever there is a very severe off phenomenon, you can give apomorphine. Is that right? Of course, it produces very, very severe nausea. Is that right? Because it will act on the chemotrigger zone as well. And of course, no fun in telling that if it is doing excessive action, then it may produce dyskinesias, isn't it? And if, am I clear? So apomorphine is known for, it's a dramatic mobilizer for a patient of Parkinsonism who is really frozen due to off phenomenon. Now we come to another drug which we did not mention here, which was increasing synthesis of dopamine, release of dopamine, and reducing the reuptake of dopamine. That drug was Amantadine. Is that right? So a few words about that. That Amantadine, mechanism of action you already know. And recently they came to know one more mechanism of action. that it can stimulate glutaminergic receptors. You remember the initial circuit, in the very first video there was a circuit in which dopaminergic pathway was stimulating, direct and indirect pathway. Rapidly direct pathway was dopaminergic, GABAergic, then again GABAergic, and indirect pathway was GABAergic going to external pallidum, then GABAergic going to subthalamus, and from here what was this? Glutaminergic, and then there was final pathway from thalamus, glutaminergic. You remember that? Okay. Amantadine can work also here. These neurons here that stimulate the glutaminergic pathway. It is equivalent to stimulating the thalamocortical pathway and slightly increase the activity in Parkinson's patient. Is that right? Am I clear to you? So amantadine not only increases synthesis of dopamine, store of dopamine and release of dopamine, it also reduces the reuptake of dopamine. So dopamine activity in the synapse should be enhanced at postsynaptic membrane. Plus now recently they have discovered that amantadine can also enhance the glutaminergic activity by acting on NMDA receptors. Those glutamate receptors are called NMDA receptors. Clinical use of amantadine, the good news or bad news? Good news is that it works, bad news is that it works only for few weeks. After that loses its efficacy, right? And it has a lot of adverse effect, especially when amantadine can lead to release of a lot of catecholamines from some other nerve endings as well. So its adverse effect may be restlessness, or it may be anxiety or insomnia, agitations, right? Excitement, hallucinations, toxicosis related with psychosis, toxic psychosis. All these actions are due to excessive stimulation to the central nervous system, because amantadine increases not only release of dopamine in very high doses, amantadine unfortunately lead to release of epinephrine and norepinephrine from the noradrenergic nerve endings as well, right? Then another very important side effect of amantadine is Livido Reticularis. Livido Reticularis. Actually, patients who are using amantadine, they may develop some special type of skin lesions in which there are red lines, especially on the feet. Is that right? Livido reticularis. What really happens with the patient, that patient may develop some red lines on the skin, and if you stop the drug, they will disappear within few days. Please don't confuse livido reticularis with erythromyalgia, which was produced by ergot derivatives. That was more serious side effect. Is that right? Sometimes peripheral edema is produced by this drug, which can be treated by diuretics. Now we come to the last drug. Who will tell me the last drug? We have already discussed. Strategy number 1 was provide the precursors. That was levodopa. And of course, we have discussed why it should be given with carbidopa. Then second strategy was increase the synthesis, store, release, and reduce uptake, amantadine. We have discussed. Third strategy, directly stimulated. I think we have done. There was ergot derivative and non-ergot derivatives. Is that right? Then we talked about monoamine oxidase B inhibitors, selegiline, and then Comt inhibitors like tolcapone, which act centrally as well and produces liver toxicity, and entacapone, which does not enter in central nervous system but inhibits the enzyme in the periphery, right? Then we discussed apomorphine, which is a dramatic mobilizer in old people who is too much frozen, right? And then we discussed about what? We have discussed all the options. Still one group of the drug is left. What is that group? Do you remember or forgotten? Anticholinergics. Is that right? And management of Parkinsonism. I told you in Parkinson's disease, due to reduced dopaminergic activity, unopposed cholinergic, you can say activity in central nervous system and especially at striatum produces tremors and rigidity. So we can use anticholinergic drugs as well, right? And few words about the anticholinergic drugs. Actually, these drugs will be discussed in detail when we will study autonomic drugs, drugs acting on autonomic nervous system, but few words about anticholinergic drugs. Anticholinergic drugs, right, used in Parkinsonism. Of course, anticholinergic drugs which are used in Parkinsonism should be those drugs which can cross the blood-brain barrier and go to the central nervous system. Is that right? Can you tell me the name of few anticholinergics? Yes. Who's going to tell me? Benztropine? Yes, please. Benztropine? Yes. Not interested? Piperidine? Piperidine? Yes. Benztropine, piperidine, or phenadrine, procyclidine, or phenadrine, procyclidine, and the last but important name, which is very funny, trihexyphenidyl. I don't know who put this name. Trihexyphenidyl. Trihexyphenidyl. All of these drugs are anticholinergic drugs. They can go to the central nervous system and they go to the striatum and reduce the cholinergic activity, try to reduce the cholinergic activity so that it becomes balanced with the dopaminergic activity, and especially they are useful for managing the tremors and rigidity related in Parkinson's disease. The sad thing is they also go to the other parts of the body as well and produce side effects, right? Now the organs and systems which are sensitive to anticholinergic activity, of course basal ganglia, we are getting benefit, good news. But anticholinergic drug act on the whole cerebral cortex. You know, throughout the cerebral cortex, there's a lot of cholinergic neurons, right? And when anticholinergic drug work on the cerebral cortex function goes down. That will produce confusion. Especially in elderly patients too much, so forgetfulness, confusion. And then confusion may go into some undue stimulation of central nervous system, right? Now, this is one problem. Secondly, they can act on the anticholinergic, can act on the heart and produce arrhythmias. And you know, acetylcholine is motor to GIT. So they can produce constipation or fecal retention. And acetylcholine is also motor to urinary bladder. So they can lead to urinary retention, especially in the patient with benign prostatic hypertrophy. Elderly males usually have a trouble with the prostate at the top. You give them anticholinergic, they will develop urinary retention. And we forgot to mention that in the eyes also, yeah, beautiful eyes. Anticholinergic produces what thing? Cycloplegia. What is cycloplegia? There's some cycle which does not work there. You know, ciliaris muscle, which is concerned with accommodation, right? It adjusts the lens. Ciliaris muscle. Ciliaris muscle is moved by cholinergic fibers, and anticholinergic drug block the cholinergic receptors. Of course, muscarinic receptors. They are cholinergic muscarinic receptors in the ciliary muscle. And when ciliaris is paralyzed, we say there is cycloplegia, and lens cannot accommodate well. Can lens adjust? If lens cannot adjust, patient develop blurring of vision. Now you imagine an old man, unfortunately, who was a very unfortunate old man who was having Parkinsonism, and you as a young doctor decide to give him anticholinergic in heavy doses. What will happen? Of course, his tremor and rigidity will go down, but he will develop confusion, forgetfulness, right? With that, he will develop blurring of vision, which is already has visual problem. Maybe now he develop further blurring of vision. He develop dry mouth. You know, cholinergic system stimulate the parotid gland. So he may develop dry mouth. He may develop cardiac arrhythmias. He may develop fecal retention. He may develop urinary retention. Do you think he will be a happy old man? He will be very sad because some doctor was efficient to give him anticholinergic drugs. So when you are using anticholinergic drugs in any old man, this principle is not only old man with Parkinson's disease, any old man, when you are thinking of giving him anticholinergics, please rethink, right? Now we come to some drugs are finished related with Parkinson's disease, good luck. Okay, some surgical procedures, right? Some surgical procedures, they were very commonly used in 1950s and 60s, and then we lost interest, and now again there was some interest in 90s to do some surgical procedures. One surgical procedure is they do some damage to the thalamus. That is called thalamotomy. What is that called? Thalamotomy. Right? Another is that produce some lesions, surgical lesions in globus pallidus. That is called pallidotomy. The best thing is not to have them, right? Because even though in some patients after thalamotomy and pallidotomy, some of the clinical problems related with the Parkinsonism are reduced, but side effects of these procedures are very high. The risk of doing this procedure is very high. Secondly, some patients, when you do these procedures, they don't get any benefit. And the worse, in some patients, even the symptoms become excessive. And unfortunately, once you produce these lesions surgically, they are irreversible. There is some better option available now, that is thalamic stimulator stimulation. Thalamic stimulation. Right? They place some electrode, and that electrode stimulates the thalamus, and especially those nuclei which are concerned with the motor system, ventroanterior and ventrolateral nucleus of the thalamus, and when these nuclei are stimulated, that produces activation of the glutaminergic pathway, which are thalamocortical pathways. In some patients, it gives really significant improvement, but in those patients where improvement is not significant, we can remove these electrodes. So this process is reversible. Then another approach which is being tried is transplantation of dopaminergic tissue, from the fetus. I mean, sometimes there are intrauterine death, and from the fetus they remove the substantia nigra and transplant into Parkinson's disease patient. These transplant work at least for few months. The patient feels better, but again, it's not worth it. They are doing experiments. Right now, at the best, we can say this is experimental approach, because usually they don't work for long, and for few months of mobility, you are paying really heavy price if you are going for a big neurosurgical procedure. Is that right? But these things are being. Then, yes, we are really in search of neuroprotective drugs. We are really in search of neuroprotective drug, right? And there was a dramatic change in the research on Parkinson's disease after some unfortunate event, that in I think California, there was a amateur chemist who was making some Mptp. Mptp is a drug which was being used at that time by some opioid addicts. Let me tell you what exactly happened. Actually, suddenly there was some patients started coming in big number to the doctors in California, and they were having young patients, previously very healthy patients, and they were found having very, very severe type of Parkinsonism. And it was very big alarming thing that many patients coming to doctors, and they are having a young man of 22 or 18 years old and a woman of just 21-year-old, right? And she is having severe hypokinesia with tremors and rigidity and looking like an old lady with Parkinsonism. The doctor was surprised what is happening. When they little bit probed it, they came to know these were the people who were addicts to opiate drugs, and they recently found a very cheap supply. There was someone who was homemade type of Mptp by some laboratory procedure, and that Mptp has a contaminant. Right? During the procedure, there was some neurotoxic substance was present. That substance was later called, what was that called? Mppt, right? That substance is called Mptp, okay, sorry. Mptp. This was a substance which was present in that contaminated addiction material. And what was happening, that material was being taken by young people and they were using it as opioid, you can say, addiction. And what doctors found that this substance Mptp was specially taken up by pars compacta of the substantia nigra, and these neurons could concentrate this material, and within those neurons, this toxic substance was acted upon by monoamine oxidase B and converted into highly reactive and toxic compound Mpp plus. So what was happening? That there was a toxic substance present into meperidine supply, and that substance which was Mptp was specially concentrated in nigrostriatal neurons, and there this substance was further, you can say, altered by monoamine oxidase B into highly reactive compounds, and those reactive compounds were destroying very rapidly and efficiently, unfortunately, nigrostriatal pathway, and there was sudden onset of very severe Parkinson's disease. This was sad, of course, but that put a big thrust of research that doctors thought then it means that people who are developing Parkinson's disease in the age of 60 or 70, probably there is some neurotoxic compound like this which is destroying substantia nigra, or its, what is that? Its derivative terminals in the striatum, right? Actually, now they believe that there may be some inherited tendency, but at the top there is some environmental neurotoxic substance. We are yet not knowing that. That is probably like these substances, it is getting accumulated into those substantia nigra neurons and destroying them. Is that right? Doctors think if we can neutralize that substance and protect the nigrostriatal pathway against those neurotoxic products, that will be a big, big achievement, right? And you know what really happens when substantia nigra neurons are destroyed? When these neurons undergo process of destruction, they lose the, dopamine. One of the derivative of dopamine is melanin, which make a black color in substantia nigra. So substantia nigra loses black color. Plus it develops some aggregates of intermediate filaments, and those pathological aggregates of intermediate filaments are called Levy bodies. So actually, patient who have Parkinson's disease in their substantia nigra, this loses its black color and it develops Levy bodies, which are tangled masses of intermediate filaments. Is that right? And these are pathologic lesions which are produced in substantia nigra during the progression of Parkinson's disease. Now, the result of all this research is that now doctors are looking for some substances which can act as neuroprotective for these neurons. And there are a lot of research going on, antioxidants, or some substances which are anti-apoptotic, or some substance which are glutamate antagonists, because recent research is that excessive glutaminergic activity can load the neurons with toxic amount of calcium, and neurons undergo apoptosis. So they are thinking again, in some neurons, if glutaminergic activity become very high, right, glutaminergic activity opens calcium channels, then neurons become overloaded with calcium. If neurons are loaded with massive amount of calcium, calcium kills the neuron. Normally calcium is good for neuron function, it releases the neurotransmitters, but in toxic amount, excess of everything bad. So excessive calcium goes into the neurons and activate the apoptotic pathway, and that may lead to a destruction of neurons. So this is called excitotoxicity, because normally calcium excites the neuron, but super excitation can kill you and even neurons, right? So now they are looking for drugs which can antagonize the glutamic acid activity. So glutamate antagonist. Then in the research they are also using glial tissue derived neurotrophic substances. Some of our glial cells produce some chemical substance which are trophic for the neurons, which help the neurons to grow. And they are thinking that if they can make some substances like this which are neurotropic, they can stimulate the neuronal growth, right? Maybe they can direct those substances to substantia nigra, and at least further loss of the neuron is prevented, and at the best maybe you get some new neuron if there are some stem cells. Neurons don't multiply, but now recent research is showing even in the adult brain there are some neuronal stem cells present which can be activated to produce more new neurons. Right, then they are also working on coenzyme Q10 and creatine because they think that they can also act as neuroprotective substances. Let them do the research and let's hope, pray they become very successful in near future so I can teach you how to arrest the progression of loss of nigrostriatal pathway, right? Until that, you just master these drugs. Goodbye. Thank you. Today we will discuss the management of other movement disorders. Other movement disorders mean movement disorders other than the Parkinson disease. We have already discussed the pharmacological management of the Parkinson's disease in detail. Now a few words about other movement disorders and their management. First of all, we'll talk about the tremors. How do you define tremors? Don't tell me tremors are tremors. Yes. Who will define what are tremors? Tremors are rhythmic oscillatory movements, right, around a joint. Rhythmic oscillatory movement, these are rhythmic oscillations, right, around a joint. Now there are many types of tremors. Let's first of all discuss physiological postural tremors. Physiological postural tremors. These are very normal tremors, physiological tremors, right? With outstretched hand, everyone has a little bit tremors, not too much, because if they're too much, there must be something wrong, right? So physiological postural tremors are normal and they may be enhanced under certain circumstances. For example, your physiological postural tremors may be enhanced during anxiety. When you are anxious, tremors become more, right? They may be enhanced in anxiety. They may be enhanced when you're very much fatigued. They may be enhanced in thyrotoxicosis, all of you must be knowing, right? And such tremors may be enhanced with intravenous catecholamine injections, right? These tremors may also be enhanced by bronchodilator drugs. Why bronchodilator drugs may produce tremors? You know, salbutamol or terbutaline, these drugs are beta-2 stimulant. And you know, muscle spindles, within the muscles, there are muscle spindles, they also have beta-2 receptors. So when muscle spindles are unduly stimulated, they become dysfunctional and they produce tremors, right? So what really happens that bronchodilators can produce tremors, even tricyclic antidepressants can also produce tremor. What is the mechanism of tricyclic antidepressants? Tricyclic antidepressants do not allow the sympathetic nerve endings, noradrenergic and adrenergic and dopaminergic or even serotonergic nerve endings to reuptake their neurotransmitter. For example, if this is a neuron which releases norepinephrine, so it is noradrenergic nerve ending. Now, of course, this norepinephrine will work on the postsynaptic membrane, but most of it will be recaptured by, what is this? Reuptake 1 mechanism. And there are, you must know, there are many substances which block this reuptake 1 mechanism. What are these substances which block? Number one, TCAs. Tricyclic antidepressants bind with the proteins which are concerned with reuptake mechanisms and block them. Then naturally, the concentration of norepinephrine in the synapses become more. In the same way, cocaine can also block reuptake mechanism so that sympathetic endings release the norepinephrine, they cannot reuptake. Is that right? Anyway, so what I was talking about, that people who are using tricyclic antidepressants, naturally the nerve endings when they are releasing monoamine neurotransmitters, they are not reuptaken, their concentration become more and their action on postsynaptic membrane become more. Is that right? So that is exactly what happens even at all the sympathetic nervous system sometimes, and that may produce tremors. As anxiety enhances tremor, in the same way TCAs also enhance the tremors. Then lithium drug, lithium carbonate, they also enhance the tremors. We will discuss when I will teach you the lithium. Now these tremors, which are called physiological postural tremor, they are mediated by beta 2 adrenergic receptors, right? So if they are really problematic for the patient, right, as I told you that these tremors become very much excessive, or they are exaggerated during anxiety, or they become exaggerated during thyrotoxicosis, they become exaggerated when you are very much fatigued, or they may become exaggerated when you are taking bronchodilators, especially. Which bronchodilators? Beta 2 stimulant bronchodilators, or someone is on TCAs, right? So these tremors which are mediated by the beta 2 adrenergic receptor stimulation, they can be ameliorated or treated or suppressed by giving beta 2 blockers, beta 1 and beta 2 blockers. Of course, at the top, the name which should come to your mind is propranolol. So they can be treated by propranolol. Is that right? Of course, propranolol is non-selective beta blocker. It blocks the beta 1 receptor as well as it blocks the, yes, beta 2 receptors. Is that right? So propranolol is a treatment by that. Then you have to compare the physiological postural tremor with the essential tremors. These are different tremors. Essential tremors. Essential tremors may even be familial. Is that right? The important thing in the essential tremor is that essential tremors are mediated by, yes, they are mediated by beta 1 adrenergic receptors. They are mediated by beta 1 adrenergic receptor, and this concept has some clinical implication, right? That people who come with the essential tremors, if you want to reduce their tremor, of course, propranolol can be useful here also, because propranolol block beta 1 and beta 2 both receptors. So propranolol can reduce the physiological postural tremor as well as it can reduce the essential tremor. But the point which you have to remember that physiological postural tremors are mediated by beta 2 and essential tremors are mediated by beta 1. The advantage of remembering this point is that if you come across a patient who has essential tremors, and if propranolol is contraindicated because it has non-selective beta blockers, you can use in these patients under those circumstances beta 1 selective blockers. Beta 1 selective blockers, classical example may be metoprolol. Metoprolol in pharmacological doses, it mainly blocks beta 1 adrenergic receptor, and of course at very high doses even it loses its selectivity. So we use the low doses of metoprolol in the patients with essential tremors, and that will be enough to control the tremors. Another point which is very important, that when you are using the propranolol, you must know what are the important contraindications to propranolol. Yes, madam, will you tell me the contraindications to propranolol? Even though we have discussed the contraindications to propranolol in very big detail in the videos related with the cardiovascular drugs, right? But just if you remember, you should know at least 5 contraindications of propranolol. Every good doctor should know at least 5 contraindications. Number 1 is COPD. What is COPD? Chronic obstructive pulmonary diseases. For example, asthma. Patient who has asthma, if you give them propranolol, propranolol will block the beta 1 and beta 2 receptors both, and beta 2 receptors in bronchial smooth muscles are bronchodilator. When you give the propranolol, beta 2 receptors are blocked in the bronchial smooth muscles, and when beta 2 receptors in the bronchial smooth muscles are blocked, bronchial smooth muscles will undergo bronchoconstriction, and if patient has a tendency of asthma, that may precipitate asthma. Again listen, that bronchial smooth muscles undergo beta 2 mediated bronchodilation, and when you give propranolol, patient loses the beta 2 mediated bronchodilation, and there is a tendency of precipitation of asthma if he has an underlying tendency for that, right? So in chronic obstructive pulmonary diseases, right, like chronic bronchitis or asthma, it's wise to avoid propranolol because it can block beta 2 receptors and lead to bronchoconstriction. Am I clear? Another contraindication is severe congestive cardiac failure. Severe congestive cardiac failure. You must be knowing that heart is having beta 1 receptors. Is that right? Now, listen carefully. Our endogenous epinephrine and norepinephrine work on the beta 1 receptors of the ventriculomyocardium, and there the sympathetic drive is positive inotropic. Actually, the patients who are having congestive cardiac failure, their sympathetic nervous system fires more to provide more epinephrine and norepinephrine to the heart. One of the advantages of this excessive amount of epinephrine and norepinephrine is that these drugs, these neurotransmitters or these hormones, they work on the beta 1 receptors on the myocardium, and they work as positive inotropic. They increase the contractility of the heart. Now, if a patient is having congestive cardiac failure, at the top you give them propranolol, and propranolol goes and block the beta 1 receptor, then patient will lose beta 1 mediated positive inotropic action on the heart, and patient may go into intractable cardiac failure. Am I clear? No problem into this? Another contraindication which all good doctors should know, contraindication to propranolol is, yes, cardiac bradyarrhythmia, especially when we talk about the heart block. You know, heart block is also called nodal block, or it is called junctional block. When AV node is unduly suppressed, right? If someone's AV node is not conducting the current from atria to ventricle properly, right, at the top you give propranolol. Naturally, when propranolol will block the, listen, this is AV node also has beta 1 receptor, is that right? And normally epinephrine and norepinephrine stimulate the AV node a little, and that action of epinephrine and norepinephrine, which is stimulatory on the conduction of AV node, that action is called positive dromotropic action. What is that called? Positive dromotropic action. Is that right? So epinephrine, norepinephrine has positive dromotropic action on AV node. Positive dromotropic action means that positive effect on the conduction of the cardiac impulse through the AV node. Am I clear? Now, if patient has already, you can say, suppressed AV node, which is poorly conducting the atrial cardiac impulse from atria to the ventricle, at the top you give the propranolol for any indication, then AV node will lose the beta 1 mediated positive dromotropic action. What will happen? That AV node will lose the beta 1 mediated positive dromotropic action, and maybe first degree heart block may convert into second degree heart block or even third degree heart block, that is complete heart block. Third degree heart block means complete heart block. It means the AV node is not conducting any cardiac impulse from the atria to the ventricle, right? So you have to be very careful when you give beta blocker to patient of COPD, so that there should not be loss of beta 2 mediated bronchodilation. You should be careful when you give the beta blockers to the patient with severe cardiac failure, so that patient should not lose beta 1 mediated positive inotropic action. You must be careful when you use the beta blockers in patient with heart block, so that AV node and conduction system does not lose the positive dromotropic action. Am I right? Then in patients on insulin dependent diabetes mellitus, patients who are on insulin dependent diabetes mellitus, right? It's not wise to give them propranolol. Why? Because insulin dependent diabetes mellitus patient sometimes undergo severe hypoglycemia. Let me tell you how. Let's suppose I have a very severe deficiency of insulin, and to keep my sugar level in check, you put me on insulin injections. Fine. Sometimes patient may take the insulin injection but does not eat well or vomit out or exercise too much, Under these circumstances, patient may undergo severe hypoglycemia. So first thing you have to understand that diabetic patient who are on the insulin, they have a tendency to undergo severe hypoglycemias when after injecting insulin they don't eat well, or they vomit out, or they exercise too much, or some other reasons. Now normally what happens? Normally when you develop severe hypoglycemia, two things happen. Whenever your glucose level in the blood goes down, two things happen. Number one, severe hypoglycemia will stimulate sympathetic outflow. That will increase, you can say, stimulate the vasomotor center, and that will lead to sympathetic outflow. Actually, whenever any person develops very severe hypoglycemia, sympathetic outflow will occur, and that will produce tremors, palpitations, sweating, and some behavioral changes. These are the warning signs of hypoglycemia. If patient is on beta blocker drugs, beta 1 and beta 2 receptors are blocked, he will not develop palpitation, he will not develop tremors. So such patient who is insulin dependent, and if he is undergoing a severe hypoglycemic episode, right, hypoglycemia will stimulate the sympathetic outflow, but because sympathetic receptors are blocked, so tremors will not develop, palpitations will not develop, so warning signs of hypoglycemia will be masked. So patient will not be aware that he is undergoing hypoglycemia, because usually when these patients become aware of hypoglycemia due to tremors or due to palpitations, they abort the attack of hypoglycemia by taking a lump of sugar. So this is one problem, that insulin dependent diabetic patients should not be given beta blocker for multiple reasons. One reason is that such patients, when they go under hypoglycemic attack, sympathetic overflow does occur, but it failed to produce the warning signs as adrenergic receptors are blocked by propranolol, and due to masking of the warning signs, patient is not aware of this hypoglycemic episode, and patient does not abort it by taking some exogenous sugars. Am I clear? Second problem is, yes please, you have a question.
Yes, what about patients who are diabetic, who've had myocardial infarctions, and they suggest giving beta blockers after myocardial infarctions as a
just a minute, I will explain that. First, let me explain the second reason. Actually, second reason why in these patients we don't give the beta blocker is that usually when your sugar level goes down, epinephrine in blood, adrenal medulla also releases epinephrine. Epinephrine work on the liver cells on beta 2 receptors. And when epinephrine work on the beta 2 receptors, under the beta 2 receptors signal the hepatocyte to convert the glycogen into glucose, that is glycogenolysis, and release the glucose to blood. So it means normally when severe hypoglycemia occur, the epinephrine which is released from adrenal medulla will act on beta 2 receptors on the hepatocytes, and that will release lot of glucose through the process of glycogenolysis to prevent further drop in glucose level. Are you understanding? But if you are giving propranolol and this beta 2 receptor is also blocked, so what will happen? That patient's internal capacity to release the glucose from the liver is impaired. So hypoglycemia become further more severe. Is that right? So due to these two basic reasons, patients who are insulin dependent diabetic, we don't give them beta blockers, because beta blockers can mask the warning signs of hypoglycemia. Secondly, they also block the beta 2 receptors on the hepatocytes, and they don't allow the hepatocytes to build up enough glycogenolytic reaction to hypoglycemia and provide enough glucose to the blood, right? Yes, what was your question? Please, you will repeat it.
Yes, patients who are diabetes and insulin dependent who have myocardial infarction.
Right, you are talking about a patient who is insulin dependent diabetic. At the top, he has developed recently he has developed myocardial infarction. Yes, then
Are these patients not given beta blockers?
they should not be given. Yes, such patients should not be given beta blocker. So, beta blocker is also contraindicated in posterior inferior myocardial infarction. Why? Posterior inferior myocardial infarction occur from the posterior branch of the right coronary artery, which also supplies to AV node and SA node. So usually with posterior inferior myocardial infarction, SA node and AV nodes are also ischemic. So patient has a tendency to undergo bradyarrhythmias. All myocardial infarction produce tachyarrhythmias, but posterior inferior myocardial infarction has a tendency to produce bradyarrhythmia. At the top you give the beta blocker, you lose the patient. Is that right? Anyway, let's come back. So what is the next contraindication for beta blocker? You know, it's equally important to groom the doctors about the contraindications as much it is important that doctors know what are the indications for the drugs. Beta blockers are wonderful drugs, but you should use them judiciously, right? Yes. What is another contraindication for the beta blockers? Yes, please. You don't want to share your knowledge with me. Okay. Now I will give you a mechanism and you may guess the disease. One function of beta 2 receptor is, you know, beta 2 receptors are present on some arterioles also. And arteriole have beta 2 receptors as well as alpha 1 receptor. Now listen carefully. If alpha 1 receptor is stimulated, there is arterioconstriction. If beta 2 receptors are stimulated, there is arteriolodilation. It means that beta 2 receptor maintains some degree of arteriolodilation. Am I clear? And if you give propranolol, then some degree of beta 2 mediated arteriolodilatation may be lost. This loss of beta 2 mediated arteriolodilation become a big issue in some important disease. What is that disease? That disease is called Raynaud's disease. You know, Raynaud's disease, patient has a tendency of vasospasticity in the distal limb vessels. Raynaud's phenomenon, you know, something like that. There are some patients have a tendency that their limb vessels they have a high tendency to undergo vasospasticity. If patient has a tendency of Raynaud's disease or Raynaud's phenomenon, at the top for some other reason you give him beta blocker, what will happen? Beta 2 mediated vasodilation will be lost and precipitation of Raynaud's episode may occur. Right? There are other indications also, but these are the 5 minimum you are supposed to know. Whenever you prescribe beta blockers, always in your mind you have to be clear that patient should not have COPD, patient should not have severe congestive cardiac failure, patient should not have heart blocks, patient should not be insulin dependent, diabetes, mellitus patient, and patient should not have peripheral vascular spastic diseases. Peripheral vasospastic disease. Am I clear? Any question up to this? There's no question. Okay. So we were talking about that in case of postural tremor, physiological postural tremor, or in case of essential tremor, in both cases you can use propranolol, but you have to use it carefully. Is that right? About the essential tremor, there is something very interesting. We don't know the mechanism, but they can be relieved by intake of alcohol, at least for a while, transiently. Right? I think some people are very happy to know it. Right? The little alcohol intake may relieve the essential tremors transiently. Right? Then there are other drugs which can also be used in essential tremors. For example, some anti-epileptic drugs are used in essential tremors, right? Because anti-epileptic drug reduce the neuronal firing, and some people believe that essential tremor are due to some abnormal excessive neuronal firing. So they tried the anti-epileptic drug and some of them really worked. For example, primidone, one drug is primidone, and other is topiramate, right? Other is topiramate, right? So these two anti-epileptic drugs are also useful in patients with these. Then essential tremors can also be managed by another drug which reduces neuronal conduction by loading the neurons with chloride, some drug which stimulate the GABA channels. You know GABA channels, when they are stimulated, they load the neurons with chloride, GABA A receptors. The name of the drug is whole group of drug called the benzodiazepines. Have you heard of benzodiazepines? Right? So benzodiazepines group, especially alprazolam. So this can also be used in essential tremors, but still the best drug remains, what is this? Beta blockers, especially propranolol, and if COPD patient, you can use metoprolol. Any question up to here? Okay. Now we go to another movement disorder which is rare but very important, that is called Huntington's disease. I will mention about the Huntington's disease very briefly because we will discuss the Huntington's chorea in detail in genetics and pathology, right? But few important points. Huntington's disease or chorea. It's a very interesting phenomenon that if you compare the Huntington's disease neurotransmission problems with the Parkinson's disease neurotransmission problem, because Huntington disease has also severe neurotransmission disturbances in the basal ganglia, and Parkinson's disease has also severe neurotransmission problems in basal ganglia. Let's compare it. First, you will tell me what happens in Parkinson's disease. Dopaminergic activity is up or down? Dopaminergic activity is less. And in Parkinson's disease, acetylcholine activity is high. That is why in Parkinson's disease, what you try to do, therapeutic measures are increase the dopaminergic activity in the basal ganglia and decrease the cholinergic. Am I clear? This is a strategy in Parkinson's disease. Now let's compare it with Huntington's chorea. Huntington's chorea is, or Huntington disease is actually inherited disorder. It is autosomal dominant inherited disorder with full penetrance. And this autosomal dominant inherited disorder has its defective gene in chromosome number 4. Is that right? In chromosome number 4, there is a gene which produces a protein, and that gene has trinucleotide repeat amplification. I will discuss these things in detail when I teach you genetics. For a while, you just trust me, I'm right. That on the chromosome number 4, there is a gene in which trinucleotide repeat amplification occurs. Okay, let me make a diagram here. Here is chromosome number 4, and there is the gene. In this gene, there are trinucleotide repeat KACAG, CAG stand for cytosine, adenine, guanine, and these repeats become too much. When these repeats become too much, that produces, we say there is trinucleotide repeat amplification. That produces an abnormal protein which is called Huntington. This Huntington protein, which is expressed in the basal ganglia neurons, especially in which neurons? Suppose this is a neuron, right? Especially this protein is expressed in, this mutant or abnormal protein is expressed in cholinergic neuron and GABAergic neuron. Is that right? Now, they say that Huntington protein somehow overstimulate the glutamate receptors. You know, this glutamic acid is a neurotransmitter, right? And glutaminergic receptors present on cholinergic neurons and GABAergic neuron. When I say this neuron is cholinergic, it means it is releasing acetylcholine. If I say this neuron is GABAergic, it means it is releasing GABA. But maybe this neuron is under influence of some other neuron, and this is glutaminergic neuron. This glutaminergic neuron releases glutamic acid here, and glutamic acid bind with special type of receptors which are called NMDA receptors, N-methyl D-aspartate receptors. What are these? Glutamate receptors are called NMDA receptors. NMDA receptors mean these receptors also bind N-methyl D-aspartate, right? So glutamate bind with these receptors and these receptors lead to influx of calcium. Is that right? Now listen carefully. They believe that in patient with the Huntington's disease, there is this genetic defect produces an abnormal protein, and this abnormal protein, which is expressed in cholinergic and GABAergic neurons of basal ganglia, this abnormal protein lead to overfunctioning of glutaminergic receptors. When glutamatergic receptors are overstimulated, these neurons are underloaded with calcium or overloaded with calcium. Of course, overloaded with calcium. Am I clear? So when these neurons become overloaded with calcium, right, excessive calcium, very high concentration of calcium is toxic for the neurons. It stimulates some enzymes which destroy the DNA called DNases. These excessive calcium can stimulate proteases. It can activate phospholipases. It can activate phosphatases. So actually, massive amount of calcium which comes into cell and excites the neuron up to the level of toxicity, right? And lot of proteases, DNases, phospholipases and phosphatases are unduly stimulated. They digest away a lot of component of the cell and cell undergo apoptosis and death. So what happens in Huntington's disease? In Huntington's disease, due to defective gene which lead to production of Huntington protein lead to overfunctioning of NMDA receptors, and these NMDA receptors lead to overstimulation of these neurons with calcium, and this high amount of calcium is toxic for the neuron. This mechanism of destruction of neuron is called excitotoxicity. What is this? Excitotoxicity. So due to this excitotoxic process going on in cholinergic and GABAergic neurons within the basal ganglia lead to destruction of neurotransmission system. So what really happens that acetylcholine, cholinergic activity is less, even GABAergic activity is, yes, GABAergic activity in basal ganglia is also less, and in this case there is unopposed excessive action of dopaminergic activity in the basal ganglia. Now look at it. This is basal ganglia neurotransmission in Parkinson's disease. This is basal ganglia neurotransmission in, what is this? Huntington's disease. In Parkinson's, acetylcholine is more and dopamine is less. So we give the drugs which are dopaminergic and anticholinergic. Is that right? But principle of management of Huntington's disease is because in this disease cholinergic and GABAergic activity is less and dopaminergic activity is more. What really happens that dopaminergic activity is more. Now there are two ways, either we decrease dopaminergic activity or we increase GABAergic and acetylcholine activity. Is that right? In Huntington's disease. So up to now the pharmacological efforts to increase cholinergic or GABAergic activity in the basal ganglia of Huntington disease is not meeting with success. So we are not successful in developing any drug which can lead to significant increase in cholinergic or GABAergic activity of what? Is that right? Basal ganglia. So we are left with reducing the choice of reducing the, what is this? Dopaminergic activity, right? So in patients with Huntington's disease who develop around the age of 40 and 50, somewhere between the age of 40 and 50, they develop severe chorias due to disturbance of basal ganglia. Plus these patients also develop dementia, right? Choria and dementia. Dementia means that there is impaired intellectual function, right, with loss of recent memory. So what really happens that these patients with Huntington's disease, they develop double problem, chorea with the dementia. Some patients develop chorea first, some people develop dementia first. Or some people develop unfortunately both things together, right? Adult onset of these problems. So we don't have any cure for this disease, but what we do, we try the drugs which are anti-dopaminergic. You know those drugs when you study the antipsychotic drugs. For example, we can try phenothiazines or we can try haloperidol, butyrophenone groups, right? So these patients may be treated by phenothiazines or butyrophenones. One of the drug from the group of butyrophenone is haloperidol, which is very successfully used to reduce the chorea. Is that right? This is one thing. Secondly, in these patients, other group of drug is that in dopaminergic neurons, again, suppose this is the dopaminergic neuron, what you can do? You can do two things. Number one, it is releasing dopamine. What you can do, that number one, block these receptors. Is that right? To reduce dopaminergic activity. Of course, this action is achieved by phenothiazines or butyrophenones. Other action is they deplete these vesicles. These are dopamine storage vesicles. You deplete these vesicles. How you can deplete these vesicles? Let me bring this vesicle out. This is a vesicle and it has special type of transporters. These transporters concentrate the dopamine, synthesize dopamine from the cytoplasm into vesicles, right? And we have drugs like reserpine. This is reserpine. Or we have drugs like, there's another drug which is called tetrabenazine. Reserpine or tetrabenazine. These drugs can bind with the vesicular transport mechanism which take the dopamine from the nerve terminal cytoplasm and concentrate into vesicles. When you give the reserpine and tetrabenazine, these transporters don't work and dopamine cannot be concentrated in vesicles. It remains outside. It will be destroyed by monoamine oxidase, right? And whenever action potential comes, vesicles will move and fuse with the plasma membrane, but they will not release any dopamine. So we can say that by action of these drugs, we produce a depletion of neurotransmitter in the storage vesicles. Is that clear? Is there any question? So this is the management of, what is that? Huntington's disease. Is that right? We don't have any drugs right now which can arrest the progression of further loss of neurons, cholinergic neurons or GABAergic neurons. Now, we will discuss about the treatment of few more motor disorders. For example, you may have heard of the disease called Tourette syndrome. Tourette's syndrome. Tourette syndrome is characterized by chronic multiple motor and vocal tics. What is there? There are chronic, right? Multiple motor and vocal tics of early onset in childhood or in adolescence, right? They are motor tics and vocal tics, and sometimes they have lot of obscene vocal utterances, right? And in these patients, there is also increased association with obsessive compulsive disorder, right? It is thought that probably in this disorder, there is again neurotransmission disturbance in basal ganglia. What they really believe that probably in the basal ganglia there is excessive, you can say, dopaminergic activity in some circuits. That is why they use in this condition haloperidol, which reduces dopaminergic activity in basal ganglia, right? And another drug which is dopamine receptor antagonist is pimozide, haloperidol or pimozide. So these two drugs of choice, right? Previously we were also using Molindon, but again let me repeat, what is Tourette syndrome? It is characterized by chronic multiple motor and vocal tics of early onset. Is that right? And in these patients, what we were thinking, probably there is neurotransmission disturbed in the basal ganglia, especially there is excessive dopaminergic neurotransmission, right? That is what is producing the motor tics and probably some vocal tics as well. So we give a trial of haloperidol or pimozide. Usually it is successful. And one more treatment which they have tried in some very severe cases is thalamic stimulation. They plant the electrode in thalamus and stimulate the thalamus, right? That has also produced relief in some more severe forms of conditions. Then let's talk about one more condition, that is restless leg syndrome. Restless legs syndrome. Now what is restless leg syndrome? This is very unusual situation that patient feels a creeping discomfort arising deep in legs. Again let me repeat it. Person feels creeping severe discomfort in the legs and person is compelled to move about or move his legs. Is that right? In this restless leg syndrome, one consequence of this problem is that sleep of the patient is disturbed and patient may have daytime somnolence. Somnolence means that patient has irresistible sleep episodes in the daytime, right? Restless leg syndrome may be idiopathic or it may be associated with the pregnancy in women. Of course, pregnancy is in women. So in pregnancy in women, it may be associated or produced due to diabetic neuropathy or uremic neuropathy. In some people, it is associated with iron deficiency anemia. Now, in these patients, we try some dopamine agonist drugs or dopaminergic drugs. For example, levodopa, which can go to nerve terminals and convert into dopamine. And recently, FDA has approved a non-ergot dopamine receptor stimulator. The drug is called ropinirole. Ropinirole, right? And in some resistant cases, we can also try benzodiazepines like diazepam or clonazepam, right? So now we come to another motor disorder which is called Wilson disease. Wilson's disease. What is Wilson's disease? This is a disease, it is autosomal recessive disease in which there is defect in copper metabolism, right? And copper is unduly accumulated in liver and damages the liver and may produce cirrhosis, and it may also be unduly accumulated in basal ganglia and produce abnormal motor movements, and it may also be produced unduly. It may make a ring in the eyes, right? In the cornea at the junction of cornea with the sclera, and that grey colored ring, that is called Kayser-Fleschner ring. So there are three things. That patient in Wilson's disease, this is autosomal recessive disease where there is defective metabolism of copper. Copper is serum copper levels are low, ceruloplasmin level in the serum are low, and there is undue accumulations of copper in many tissues, especially in the liver, right? And hepatocytes accumulate toxic amount of copper and ceruloplasmin, and they undergo injury, and chronic injury may produce cirrhosis. Then copper also accumulates in basal ganglia, and that produces motor disorders. For example, these patients, due to accumulation of copper in basal ganglia, may develop tremors or rigidity, hypokinesias. These features are like Parkinson's disease, tremors, rigidity, and hypokinesias. And some patients may develop chorea, dysarthria or dysphagia due to accumulation of copper in basal ganglia. Is it right? And Kayser-Fleischer ring in the cornea. Now, of course, if copper accumulation is not prevented, too much damage to the liver or to the basal ganglia may produce very serious complications. So, the drugs which are tried, the most commonly the drug which has been used is penicillamine. Penicillamines. These are copper chelating agent. Penicillamines are given orally, they absorb in the blood, they bind with the copper, and penicillamines are lost in urine along with the copper. Is that right? So they eliminate the copper out of our body. Penicillamines, but they are very toxic. They have many side effects like nausea and vomiting, but they have dangerous side effects as well. For example, they may produce glomerulonephritis because penicillamine molecules may bind with the glomerular proteins, alter them, and autoimmune process may attack them, right? So nephrotic syndrome may be produced. Then penicillamines may also produce other autoimmune diseases which may resemble like systemic lupus erythematosus. So really it's not a very good drug. And now we have some better options available. For example, we are having potassium disulfide, Potassium disulfide can bind with the calcium within the GIT, and it is also chelating agent. It binds with the dietary calcium and does not allow the dietary calcium to be absorbed, dietary copper, sorry. It binds with the dietary copper, right, in the GIT and does not allow it to be absorbed, so there is loss of dietary copper in fecal matter. Another substance which is now available is zinc acetate. Zinc acetate is also taken orally, and this also binds with the dietary copper and does not allow it to be absorbed, and dietary copper will be lost into fecal matter. In this way it reduces the copper loading in the body. Right? So that finishes our motor disorders and their management. Is there any question? No question. Today, now we will talk about the drugs used in Alzheimer's disease. It's quite a common disease, especially in elderly people, elderly population, right? Alzheimer's disease clinically present as dementia. So what is dementia? Dementia means dementation. A lot of mental functions are lost. The hallmark of dementia is the loss of intellectual functions, of mind, plus there is loss of recent memory. Strangely, old term memory may be well retained. Loss of recent memory. And with that, there may be some other neurological deficits. For example, patient may have aphasia or apraxia or agnosia. You know what is aphasia? Difficulty in spoken language due to cortical lesions. Apraxia means loss of ability to execute learned motor movements. For example, how to cut a loaf of bread, right? Patient may forget how to do it, how to button his shirt or her shirt. Patient may forget, right? Apraxia, loss of learned motor movement. Agnosia, loss of ability to recognize common familiar objects. Is that right? So what really happens, patients with the Alzheimer's disease, they clinically present with problems of dementia. Dementia means loss of intellectual function, loss of recent memory, with some other focal disorders and behavioral abnormalities. Now, what's really wrong in Alzheimer's disease? It's a progressive disease. Is that right? In this case, there are three types of pathological lesions in the central nervous system. Number one, there is formation of senile plaques. Senile plaques of beta amyloid proteins are accumulated, beta amyloid proteins, right? They are accumulated in central nervous system. Secondly, in some neurons of the central nervous system, there is neurofibrillary tangles. Neurofibrillary tangles. And of course, a very important thing, loss of cholinergic neurons. Loss of cholinergic neurons in cerebral cortex. In cerebral cortex, especially in a very important nucleus that is called nucleus basalis of Maynard. In nucleus basalis of Maynard. Now, so what really goes wrong in the patients with Alzheimer's disease? This is basically a degenerative disease of central nervous system in which cerebral cortex undergoes degeneration, is that right, and atrophy. Especially there is loss of cholinergic neurons, and within the neurons we may find neurofibrillary tangle, and in between the neurons you may find senile plaques which are made of beta amyloid accumulations, right? Clinically, patient come with progressive deterioration of intellectual functions, higher mental functions, loss of recent memory, right? And it is strongly associated with old age. Now, in Alzheimer's disease, how do you manage the patient? There are basically two principles you have to follow. Number one, why neurodegeneration occur? Number one, why there is neurodegeneration? They believe that cause of neurodegeneration is excitotoxicity. The neurons are pathologically excited and then they undergo degeneration. Mechanism is excitotoxicity. Excitotoxicity means that in the neurons, there are glutamate receptors, and special type of glutamate receptors are called NMDA receptors, N-methyl deaspartate receptors for what? For glutamate. So when glutamate binds here, that leads to heavy influx of calcium. And they believe due to this heavy influx of calcium, right, neurons are pathologically excited, and then this pathological excitement may have toxic effect on the neurons, and neurons may undergo apoptosis and degeneration, right? Because a lot of calcium which come into neuron, it pathologically stimulates a lot of destructive enzymes. For example, yes, proteases, nucleases, phosphatases, phospholipases, right? So it's a neurodegenerative disease. Alzheimer's disease is the neurodegenerative disease in which there is some role played by excitotoxicity of the which receptors? NMDA receptors of glutamate, which are coupled with calcium channels. So one strategy of treatment of these patients will be you give some drugs which can block these NMDA receptors, right? So that further progression of disease is at least slowed down. Up to now we do not have any drug which can reverse the deficits, or we do not have any drug which can dramatically arrest the progression of the disease, right? But we have drug which can bind with the NMDA receptors of glutamate and can slightly slow down the progression of the disease, right? And the drug name is which is an altered molecule of amantadine, right? And this drug name is memantine. Easy to remember, memantine. But actually they call it memantine. But actually, just to remember, memantine. Right? If you forget this name, today imagine you are having Alzheimer's disease and you know they do some sad things. So you imagine a man who has Alzheimer's disease and continuously saying memantine. You'll remember a drug which is used there, right? Memantine. This drug has some side effects which are very similar to the disease manifestation as well. For example, this drug may produce confusion, may produce agitation, may produce restlessness, and these are not only the side effects of this drug, but these features are also the part of clinical syndrome of Alzheimer's disease as well. So one way is to reduce the excitotoxicity, and the drug is memantine. Is that right? Second is that due to loss of, as you know, that due to loss of the cholinergic neuron, there is reduced cholinergic activity in central nervous system. So you try to enhance the cholinergic activity in cerebral cortex. For that, they have found some drug which can inhibit the acetylcholinesterase enzyme. So we have drugs which can inhibit the central, especially central acetylcholinesterase enzymes inhibitor. Acetylcholinesterase enzyme inhibitors. The drugs which I will mention here, they are slightly more specific for the acetylcholinesterases in the central nervous system, right? And drugs which are here, there are 4 drugs, right? The first one is galantamine. Galantamine is competitive inhibitor of enzymes, acetylcholinesterases, right? And remaining 3 drugs are non-competitive inhibitors of enzyme. When I say that drug is competitive inhibitor of enzyme, it means when acetylcholine concentration becomes very high, drug will be displaced from enzyme. Is that right? When I say a drug is non-competitive inhibitor of the enzyme, it means even if lot of acetylcholine is there, it cannot displace the drug from the enzyme. Is that right? And now the other drugs which are non-competitive inhibitor, one is donepezil, D-O-N-E, penzil, right? Then there is rivastigmine, which should not be confused with physostigmine or neostigmine, which also inhibits acetylcholinesterases but in the periphery, preferably, right? They are used in which disease? Myasthenia gravis, right? So acetylcholinesterase inhibitors are used classically in myasthenia gravis, where physostigmine, neostigmine, right? Such drugs are used. But here we are talking about rivastigmine, which is more strongly inhibiting the central, what? Acetylcholinesterase enzymes, right? Rivastigmine and tacrine. Now, tacrine is used very less. You know why? Because it is hepatotoxic, right? Again, galantamine is competitive inhibitors, donepezil, rivastigmine and tacrine are non-competitive inhibitors of central acetylcholinesterase enzymes, right? Of course, when central acetylcholinesterase enzymes are inhibited, then acetylcholine is not destroyed because these enzymes destroy acetylcholine. So cholinergic activity in central nervous system increases. Is that clear? Now, the side effects of these drugs, they are very easy to understand. You know, these drugs, even though mainly they block or inhibit the enzymes in the central nervous system, but they do inhibit to some extent the peripheral cholinesterase enzymes as well. So naturally, in the peripheral part of the body, there is slight increase in cholinergic activity because the acetylcholine is not properly destroyed. So that may translate into, you know, acetylcholine is motor to GIT. So that may translate into GIT upsets. Right? When you give these drugs, they increase the acetyl or cholinergic activity in the GIT, and that may lead to anorexia, nausea, vomiting, diarrhea, GIT cramps, right? Am I clear? Then another thing, you know, acetylcholine is very important neurotransmitter, rather the neurotransmitter at neuromuscular junction. And when acetylcholinesterases are slightly inhibited at neuromuscular junction, a little more undue activity of acetylcholine at neuromuscular junction may produce muscular cramps, right? So many of these patients develop muscle cramps. Again, when we are talking about Alzheimer's disease, this disease is characterized by dementia. Dementia means that there is impairment of intellectual functions. With that, there is loss of recent memory, and there may be some additional feature like agnosia, apraxia, aphasias, right, which are the features due to cortical dysfunction. Is that right? In Alzheimer's disease, primarily we believe this is a disease in which there is neuronal degeneration in the cerebral cortex due to overexcitement of the neurons. So we call it excitotoxicity. This excitotoxicity is most probably due to overfunctioning of NMDA receptors for glutamate system, and lot of calcium is loaded in neurons, and that excessive amount of calcium which is loaded in the neurons overstimulate the neurons and translate into inappropriate activation of lot of destructive enzymes within the neurons and apoptosis of neurons, right? In this way, this disease is called neurodegenerative disease. Pathologically, this disease is characterized by formation of senile plaques in the central nervous system. These senile plaques are basically beta amyloid proteins, right? Plus, they are also characterized by formation of neurofibrillary tangles in the neurons, especially in cholinergic neurons. And they are also characterized by progressive loss of cholinergic neuron, especially in the cerebral cortex, right? So this is the basic pathology. The pharmacological management of disease is not very successful because we don't have any drug up to now which completely reverses the disease process, or even we don't have any drug which can really arrest the progression of the disease process. We can say the pharmacological management which we do presently, that is just a sort of palliative treatment or modestly successful, right, in preventing, you can say, further losses, delaying the further losses of the cortical functions. For example, loss of memory may be little delayed. There are two approaches. Number one, excitotoxicity mechanism should be inhibited. The drug is memantine, right? This memantine drug, right, basically it blocks the NMDA glutamate receptors. So excitotoxicity is to some extent reduced, and probably progression of disease is slightly slowed down. Second is that we try to increase the cholinergic transmission in the central nervous system. We use the drugs which are slightly more specific for central acetylcholinesterase enzymes. Drugs bind with those enzymes and inhibit them. And when central acetylcholinesterases are inhibited, naturally acetylcholine whatsoever is produced is not destroyed, and acetylcholine accumulate in central nervous system and its transmission become better, right? The drugs which are used, that is galantamine, right? That is galantamine, which is competitive inhibitor. Then there are donepezil, rivastigmine, and tacrine. Forget about this drug because it is hepatotoxic. Better to use these two or these three, right? Now, rivastigmine, donepezil, these two with tacrine are non-competitive inhibitors of acetylcholinesterase enzymes. Is that right? And galantamine is competitive inhibitor. When you use these drugs, they do produce their peripheral side effects due to increased enhance cholinergic activity in the peripheral part of the body, especially they increase the cholinergic activity in GIT, as they do block some of the acetylcholinesterase enzymes in GIT, and that increased cholinergic activity in GIT lead to abnormal motility in GIT, which will translate into anorexia, nausea and vomiting, and even it may translate into diarrhea, right? And when acetylcholinesterases even to very small extent are blocked or inhibited in neuromuscular junctions, that will translate into excessive cholinergic activity at neuromuscular junction, which may clinically produce muscle cramps, right? That's all about it.